So he's a senior consultant, co-chairman, Department of Pediatrics, Sir Gangaram Hospital. He's in charge Preeti Tulsi Thalassemia Unit at Sir Gangaram Hospital. He's also the Vice President of Thalassemic India and Regional Scientific Coordinator for India to the Thalassemic International Federation. And he has been involved and he has been in the care of thalassemic patient and research in thalassemia for last 37 years. And I don't think so anybody can match his caliber in India. Sir, it's our pleasure to have you. Over to Sir now, sir. Thank you. Dr. Khanna, sir.
Thank you, Dr. Dhankar. Now, shall we start today's academic program?
Sir, we go ahead.
Yeah. Today we will be discussing about thalassemia, mainly about its complication. Now, you see these children are growing. There was a time when we were students and junior doctors, then that time the survival of thalassemia patients was limited to the first decade or the maximum to the second decade. You get blood transfusion. So introduction of radiation therapy and newer modalities, now they are growing older. And now we are seeing complications developing because of prolonged transfusion therapy, because of prolonged chelation therapy, or those who are neglecting, especially, you see, when they reach the age of puberty, adolescence, then there is a thinking in their mind, because I have seen them for a very long time. They have been growing with me for so many years. See, they think, why me only? Why should I go for regular transfusion? So, I become very poor at this time. And then we see more and more of these complications. So we have to keep motivating them throughout for taking regular blood transfusion, maintaining pre-transfusion hemoglobin, and taking regular chelation so that they don't develop any complication. And we have to monitor them regularly. That's very important so that we can pick up these complications at the early stage. So today we have Dr. Radhika Keria, our DNB trainee from Gangaram. Then how to detect these complications, how to manage these complications, and she'll be probably taking one complication only with the patient. So over to Dr. Radhika Keria. Dr. Radhika, have you joined? Yes, please start.
So, good evening, my respected teachers and dear colleagues. Today, I'll be presenting a case of thalassemia, and we'll be discussing the complications that come with it. So my patient was a 12-year-old male residing in Delhi. His caste is Hindu. He's a Banya. The informant was his father, who's a reliable informant. This child presented to our thalassemia OPD on 20th of March 2024. He came with the chief complaints of failure to gain weight and height for the last 2 years. This child is a
Radhika. When you finish your history, then we'll discuss about the each student. Finish your history and we'll back to the first slide. Okay?
Okay, sir. Child is a known case of transfusion-dependent anemia, as told by the father. He was diagnosed at 6 months of age and on regular transfusion since then. The child has been growing well till 10 years of age, when the mother noticed that the child was not gaining height and weight when compared to peers of his age group for the last 2 years. Coming to the negative history, there is no history of irregular transfusions. There is no history of easy fatigability, palpitations, or poor appetite. There is no history of tingling of hands and feet. There is no history of muscle spasms or abdominal cramps. There is no history of constipation, dry skin, poor concentration, or lethargy. There was no history of recurrent loose stools, sticky stools, vomiting, abdominal distension, or blood in stool. The past history was not suggestive of liver disease. There was no history of recurrent infections. There is no known history of diabetes. There's no history of TB contact in the family, and there's no history of splenectomy. Treatment history. The child is receiving 2 units of packed red blood cells every 18 to 20 days. Earlier, child was getting transfused 1 unit PRBC every 3 weeks, but after 9 years of age, child was started on 2 units every 25 to 27 days. Chelation therapy. Child was started on chelation therapy at the age of 1.5 years. Currently, child is taking tablet Defrazerox, a film-coated tablet, 900 milligrams once daily. Family history. Child is born of a non-consanguineous marriage. Mother, father, and brother are diagnosed cases of thalassemia minor. No history of delayed puberty in the parents. No history of any child in the family getting repeated blood transfusions. Birth history. Antenatal history is not significant. Delivery was done by C-section. Birth weight was appropriate for gestational age. It was 2.7 kgs. The child cried immediately after birth and was admitted in NICU for phototherapy for 5 days as the child developed neonatal jaundice on day 2 of life. Developmental milestones were achieved normally as per age. The child is immunized according to the national immunization schedule. He has been immunized for hepatitis B, hepatitis A, and chickenpox according to the informant. They belong to upper class according to modified Kupuswamy scale. The diet history, there was a calorie deficit of 15% and the protein intake was adequate. To summarize, a 12-year-old male, known case of transfusion-dependent thalassemia, diagnosed at 6 months of age, came with complaints of failure to gain weight and height for the last 2 years. Family history is significant as both parents and siblings are carriers for thalassemia. There is no significant antenatal, developmental, or nutritional history.
Okay. Now, Dr. Radhika, since you are presenting a case of thalassemia, we now mention the diagnosis because there are two ways of presenting this. When you are discussing a case with complication, a known case, and then at the age of 12 years, he's been getting regular blood transfusion. Patients are both minors, so you can mention that it's a known case of thalassemia. Otherwise, when you're discussing a small child with thalassemia, then you should mention that that is a case of some hematological disorder or chronic anemia, and then he's been getting regular transfusion, because there you have to discuss the diagnosis and management and all those things. We have discussed the diagnosis and management in this forum only many times, discussing about the complications. Right? Go to the first slide now.
Yes, sir.
First slide. Go back fast. Yes. Now, next one. Yes. The important thing here is that you have to mention the caste, because thalassemia is common in certain communities. What are those communities where thalassemia is more common?
The thalassemia trait has been commonly found in Sindhis, Bhanushalis, and Punjabis.
Only that. You should come out fast. See, thalassemia is more common in Punjabis, Sindhis, Gujaratis, Marwadis, Bhanushalis, Saraswat, Gauds, Bengalis. Okay, all these. But see, with the intercaste marriage and movement of these of people, and there is no community where we don't see thalassemia. And let me mention here something, that there is no country in the world where thalassemia is not seen these days because of the movement of people. Okay, next slide. Here it should be 2024. You have written 23.
Sorry, sir.
Okay, next. Failure to gain and height. He's 12 years. For the last 2 years, he's not gaining weight and height. What are you thinking of?
So, since we know that he's a case of thalassemia major who's been on repeated blood transfusions, so from this time when the mother is complaining of slowed growth, then we can think of the complications of thalassemia. For example, the child might not be maintaining a good pre-transfusion hemoglobin. So because of the chronic hypoxia,
What is the normal hemoglobin that you recommend that these children should maintain?
So according to the TIF guidelines, we're supposed to maintain a pre-transfusion hemoglobin of 9.5 to 10.5.
Yeah, all guidelines say, not only TIF, all guidelines say, though TIF, whatever we say we that religiously, but everywhere it is mentioned that they should maintain hemoglobin, pre-transfusion hemoglobin between 9 and 10.5, because it has been seen that it does suppress the bone marrow, their own production, or ineffective erythropoiesis, and it does not affect this hemoglobin slightly lower than the normal hemoglobin of a person at that age. It does not affect the growth and development of the child. Okay?
Yes, sir.
Now, he is taking regular transfusions. Other things in the history?
Sir, delayed puberty is also something to consider in his age
We
group.
come to that. We will discuss that later. Okay, go to the next slide now.
Okay.
Transfusion dependent anemia. What are the conditions generally you think of when you see a patient at the age of 10, 12 years, and he has been taking regularly blood transfusion since the age of 6 months? What are those hematological conditions? Can you mention few conditions now here?
So, most commonly it would be thalassemia. Second, we could think of some bone marrow failure syndromes.
Yes. Or anything else?
Yes, sir. So bone marrow failure syndromes like Diamond Blackfan syndrome.
That will have some skeletal deformities also.
So pure red cell aplasia might also
Yes, might also.
because of
Sometimes it is
parvovirus.
difficult to differentiate clinically. Then you have to take help of the lab in those cases. And then some enzyme defect. Do you know?
So pyruvate kinase deficiency.
Yes. If you have ruled out thalassemia at this stage and think of pyruvate kinase deficiency also. See, it has been seen. Now, next point. See, you have written here yourself only that the child was growing well till the age of 10 years. In cases of thalassemia, we have seen many times that even if the child is maintaining good hemoglobin, taking regular chelation, but the growth stops or slows down after the age of 10 years due to many reasons we'll be discussing. One of them is the delayed onset of and many factors. Okay, you have mentioned a classical thing that we see in thalassemia patients. Right. Next. Yeah, these are the negative history. Can you just mention quickly why have you taken these negative histories in this?
Yes, sir. So no history of irregular transfusions.
Okay, fine.
This
Next.
is hypoxia. So easy fatigability, palpitations, poor appetite for again for anemia, sir. Not maintaining a pre-transfusion hemoglobin. So tingling of hands and feet for B12 folate deficiencies. Some muscle spasms and abdominal cramps for hypocalcemia and vitamin D deficiency. Constipation, dry skin, poor concentration for hypothyroidism, sir, and recurrent loose stools, sticky stools, vomiting. So these are for malabsorption syndromes, nutritional deficiencies that could lead to poor growth, celiac disease that is associated with.
One thing important that you must keep in mind when a child is not growing, that celiac disease we do see in thalassemia. I don't know. We have seen many cases of thalassemia having celiac. So we should not ignore this. We should always keep in mind. Next. Okay, there is no history of TB and diabetes and liver disease. Okay, next. Why have you taken history of no recurrent infection?
So, transfusion transmitted infections like HIV,
Yes.
uh,
Yeah, they are
it
more
could
prone
suggest.
to get this. Though nowadays, what is the latest that we are checking to prevent
So we are doing nucleic acid
transfusion transmitted
testing.
infections?
So nucleic acid testing is done on
Nucleic
blood,
acid
NAT testing.
amplification test. Yeah, nucleic acid or a nucleic acid amplification test, NAT test बोलते हैं. So
Yes,
how
sir.
does it help?
So when we are doing serological tests, then we can miss the infections in the window period. But if we do NAT testing on blood, then we can catch the infections even in the window period, because then we'll be concentrating on the nucleic acid, and we don't have to wait for the antibody or the antibodies
Yeah,
to form.
partly right, because it reduces the window period duration. Not that all cases, some cases in the early phase, maybe first week or second week of acquiring infection, maybe missed, but it reduces the window period significantly. Okay,
Yes, sir.
next. Next. Yeah, as the child grows, you are right. They have given you right history that initially when they come to us, initially they require uh, less blood because of their body weight. How much blood do you transfuse at a time?
So we give around 10 to 15 ml per kg of blood.
Yeah, 15 to 20 ml, because we are using 60%
Hematocrit.
hematocrit blood. So 15 to 20 ml to the round figure at a time. Okay. And chelation was, you've written 900 milligram once daily, deferoxyrox film coated. What is the strength of the deferoxyrox that you get in the market? Means
So
from the
500 and
company.
1,000 mg tablets.
No, deferoxyrox film coated tablet available at 360, 180, and 90 milligram tablets, and deferoxyrox plain dispersible tablets are 500 and 250. Clear?
Yes, sir.
And you've written at the age of 1.5. When do you start chelation?
So we should start chelation if serum ferritin is more than 1,000, or generally after
1000
10,000
watt? 1000 watt?
nanograms, 1,000 nanograms per ml.
Okay,
Or
fine.
if so, the after 10 to 14 blood
10
transfusions,
to
then we
12
can.
transfusions, generally the ferritin will reach around 1000. And at what level of hemoglobin you start regular blood transfusion in a case of diagnosed thalassemia major?
So we need two recordings of hemoglobin being less than 7, 2 weeks apart.
And one thing important here is that you should have ruled out other causes of low hemoglobin, like trauma leading to hemorrhage or chronic infection or something like that. Okay?
Yes, sir.
Or acute infection can reduce the hemoglobin. Okay, next. Family history, brother diagnosed and we didn't know. Okay. Now, what is the inheritance pattern of thalassemia?
So it is autosomal recessive.
Yes. So if the parents ask, what are the chances of their having a thalassemia baby in the next pregnancy? What will you tell them?
So 25% chance is there for a thalassemia major child.
No, they have already had one child, thalassemia. So in the next pregnancy, is there any different chance? No.
No, so it stays the same 25%.
Yes, absolutely right, because thalassemia is an autosomal recessive inheritance pattern, Mendelian, and every pregnancy has the same chance. Law of probability has no memory. So every pregnancy has 25% chance of having thalassemia major child. Okay. Right. Next. Do you know that, Radhika, tell me, How do you diagnose thal minor? When do you suspect thal minor
So,
in CBC?
in CBC, when we are getting a Menzer index of less than 13, then we
Yes.
start thinking of, and peripheral smear is
When
showing
MCV, MCH is low and RBC is in the normal range or on the high
high
side.
side.
Okay, next, then how do you confirm the diagnosis of thalassemia, whether it is major or minor? How do you confirm?
So, we'll do an HPLC, high pressure liquid chromatography test, and we'll check the
Yes.
proportions of different
What is the cutoff
hemoglobins.
value? No, what is the cutoff hemoglobin of A2 that will diagnose thal minor?
So more than 4%, if it's there, then we'll say that it is in the thal minor.
3.5%.
3.5.
3.5 to 4 you can keep as some doubtful, but more than 3.5 we take as cutoff for diagnosing thal minor. Okay. Next. Which type of thalassemia do we see in North India?
The beta thalassemia.
And where do you see E beta thal?
So Andhra Pradesh and
Eastern part of India,
Northeast
Southeast Asia and eastern part of India. We see E hemoglobin disease. Okay, next. Birth you were okay. What do you see features of thalassemia at birth?
No, sir.
Why? At what age generally it presents?
So generally, thal major cases will present between 6 to 8 months, 6 to 8 months of life, because that is around the time when hemoglobin F is converted into it. So because
yes, that is the time, because at birth there is fetal switch off. So gradually the fetal hemoglobin goes down and the adult hemoglobin takes. But when there is fetal, means adult hemoglobin is not formed, then they start presenting, because till that time fetal hemoglobin is there to prevent the basic defect in thalassemia is mismatch of alpha and beta group of chains. Okay. Next. Development is okay. Then next. Do they have any developmental delay? Thalassemic? Those who are well maintained?
No, sir.
No, mentally also they are normal, and developmentally also they are normal children. They don't have their right production of their RBCs. We provide them RBC from outside, and rest everything is okay for them. And then before you start them on first transfusion, you must make sure that they have received hepatitis B vaccine, because that is a preventable transfusion transmitted infection. Okay. And since their liver is compromised, hepatitis A vaccine should be then given. And CDC and others, everybody considers them as immunodeficient children or patients. So they must receive other vaccines also, like chickenpox and typhoid. Okay, next. Okay, next. Fine. Okay. Next. Summarize. Now, shall we go ahead, or anybody wants to ask her anything in the history? Madam, Dr. Madhu, Dr. Ruchira?
Sir, it's going great. I think, sir, it's going great.
Okay, we'll go ahead with it.
Sir, I just want to add a comment.
Yes.
It's Dr. Mukesh Dhankar, sir. So I just want to add the incidence of thalassemia trait in general population is about 3.3%. And definitely it is more in, as you mentioned, in Sindhis, Punjabis, Gujaratis. So in general, it is 3.3 in the general population of any community in India. And even celebrities like Amitabh Bachchan is thal trait. Even his son is thal trait. Jackie Shroff is also thal trait. So it's fine.
No, Jackie Shroff is not thaltrate.
Sir, I
He's
think
he's thalassemia ambassador. For
he mentioned that in one of our.
No, he just mentioned it. He's not a thaltrate. I know
So
him
maybe
because I keep meeting him.
Okay, fine. It's fine. He last year in PCNI he said that maybe.
Yeah.
Maybe. So it's about 3.3%. So in general population also, it's not that uncommon. So out of every 100 in India, about 3% are thaltrate. So that's a big chunk.
Yeah.
So
it's not uncommon.
Not on. Sir, there is one question. Somebody has asked whether we can diagnose thalassemia before 6 months of age. Please, can you take up that question?
We can diagnose thalassemia before 6 months of age. We can diagnose thalassemia even at birth also. We can't diagnose on the basis of HPLC. Here we have to go for mutation analysis, DNA testing, right? If the family is very disturbed and both the parents are Thal minor, they want to confirm the diagnosis. Even if at 2-3 months with the help of HPLC we have diagnosed, but to confirm at birth we can do mutation analysis and we'll come to know immediately, because that is the same test we use for antenatal diagnosis.
So right? True, sir. Right, sir. That was the only question in the chat box till now. Right, sir. We go ahead.
Radhika, quickly go ahead with the examination.
Yes, sir.
Sir, why are you taking so long to change the slide? Yes.
If you don't mind, Dr. Khanna, sir, why this child is been born as major when the two parents are minor? Why was prenatal screening not advised?
Yesterday only I got a patient from Rudrapur, where mother was diagnosed as thalassemia minor at the gestation of 6 months. And after a month, husband was also confirmed thalassemia minor. Mother was thalassemia minor at 6 months. So they had to take a chance, because our law doesn't allow termination after a certain period. So the child born was is thalassemia major. And today we have given him the first blood transfusion.
I think in this case, it would have been कि बाद में जब baby का major हो गया तब mother के father के test हुए हों. That could have been the reason. Otherwise,
no. See, I don't know for what reason they diagnosed mother late as thalassemia minor. 6 months of pregnancy already. So it was too late. So in those cases, we need to confirm, like if they wanted to know whether thalassemia major is there in child, so we could have confirmed with mutation analysis at birth. Okay. Shall we go ahead? Okay.
So, right, sir. I just want to add a point. Like we do HIV in antenatal period, so is the HPLC now mandatory for all pregnant ladies to undergo an HPLC test now. If that is normal, then we go ahead with the HPLC.
अब सर 3-4 दिन से ना 40 ज़्यादा कर रहे हैं, मतलब बहुत ज़्यादा नहीं.
Okay, shall we go ahead? Chalo, Radhika, quickly.
Yes, sir. General examination. The child was laying comfortably on the bed, conscious, oriented to time, place, and person. After taking proper consent from the informant, the child was examined in supine position. There was no pallor, icterus, clubbing, cyanosis, koilonychia, lymphadenopathy, or edema. Vital signs: heart rate was 78 per minute.
Do you have thalassemia major with icterus who is well transfused with jaundice?
Sir, no, sir, because extramedullary hematopoiesis would not be there. So
we suppress hematopoiesis, extramedullary hematopoiesis, and in fact, in thalassemia major, there is not much hemolysis at that time. Thalassemia intermedia or NTDT may present with icterus, but generally thal majors don't have. Okay, we go to the next slide because rest of the things are normal. One thing you must remember, that all thalassemics have slightly lower blood pressure. Don't get scared if you find blood pressure of 100/60 in a thalassemia patient. Don't get scared. Okay, next we go ahead.
Coming to head to toe examination, hair is normal, eyes are normal, cheekbones are normal, oral cavity is normal.
Can you quickly describe thalassemia faces?
Yes, sir.
Hemolytic faces, what we call.
Yes, so there'll be bossing of the frontal bones,
Yes.
and there'll be depression of the nasal bridge, and
Yes.
maxillary hyperplasia would be seen.
And what happens to their teeth when they grow? If
So
that is seen, yeah, their space is increased, they are mal positioned, okay,
yes, sir.
mal-occluded. See, nowadays we don't see thalassemia or hemolytic faces in children, especially those who are diagnosed early and transfused early. Those who are well maintained, we don't see them in. No features of thalassemia are there. You can't make out from a distance on seeing them that they are thalassemia patients. Okay. Why you mentioned skin, no hyperpigmentation. Why?
So chronic iron overload can lead to hyperpigmentation. So,
What is the reason for that?
so ferritin, when it
Two reasons. One is stimulation of the melanocytes and direct deposition of the iron in the skin.
Yeah.
And you mentioned petechiae. Why?
So any
Quickly, because of for thrombocytopenia, which they may develop because of hypersplenism. Okay.
Yes, sir. Yes, sir.
Go ahead next.
So upper limbs and lower limbs are normal. There are no leg ulcers. Chest, back, and spine are normal. Abdomen is normal. Genitalia, SMR stage 1.
Let me tell you one thing. If you see a thalassemia patient and when he's standing in front of you, his trunk is little shorter than other children and the upper limbs appear longer. That is because of many of them, because of they develop
So flattened
flattening
vertebrae.
flattening of the vertebra, which may be because of chelation therapy also, especially desferal.
Desferal.
And the SMR staging, you have done good. Stage 1. What does it mean, stage 1?
So in boys, it means that there is no testicular volume is less than 4 ml.
Do you have orchidometer? Have you seen orchidometer? Let me
Yes,
show
sir.
you. This is the orchidometer that we have. And this is wooden original orchidometer with me. First 3 are pre-pubertal. From 4 ml, we start with puberty. This is the 4 ml. Yes. Testes is measured in ml, not in centimeters. Next. Yes. Now, this is the most important from your history. Okay, go ahead.
So height is 137 centimeters, which was between 3rd and 10th centile. Weight is 37.5 kgs, which is between 25th and 50th centile. BMI is 19.9, which is normal according to WHO chart. Upper segment to lower segment ratio is 0.95. Upper segment being 67 centimeters in length and lower segment being 70 centimeters in length.
Again, here, upper segment may be ratio may be lower in thalassemia. Those who are who have received excess of desferon, or because of this thing osteoporosis, if there is compression of the vertebra. Okay. His mid-parental height is 170 centimeters. What is the expected at this age according to the mid-parental height? Did you calculate? And whenever you present a case of thalassemia, you should always check the sitting height. Yes. You know it. Why didn't you check? Why didn't you check?
Upper segment.
Okay. Okay. Next. So you should check mid-parental height, and according to that height percentile, what is the expected height for this age of this child? Okay. If it is less than 5 to 6 to 7 centimeters, then we investigate them. But here also it is important, like in your chart, you are showing that, see, till the age of almost 10 years he was going, and after that there is a decline, though weight is okay for this. So basically it is a height, growth velocity of height which is less, no?
Yes, sir.
Okay. Okay, next. This is BMI. Next.
Coming to the systemic examination per abdomen, abdomen is soft, non-distended. Umbilicus is central and inverted. Corresponding quadrants move equally with respiration. No dilated veins or scars present. Hernial orifices are normal. Palpation, there is no local rise of temperature. There is no tenderness. On deep palpation, the spleen is in the left hypochondrium moves with respiration, firm in consistency, smooth surface, sharp border, 3 centimeters below the left costal margin. The liver is felt in the right
In which
hypochondrium.
direction you measure the spleen?
So,
From mid-clavicular line towards?
Towards the border of the spleen, sir. We start from the right iliac fossa.
To the
and then-
maximum in the direction of the right iliac fossa. No? That
Yes.
spleen grows in that direction. Okay. Liver, you think liver is last 3 centimeter below right costal margin?
Yes, sir. Liver is felt in the right
Liver
hypochondrium.
span normal. How much liver span do you expect in a child of 11, 12 years?
So 8-9 centimeters we can
Yeah,
expect.
8 to 10
normal.
centimeters roughly. Itna hi hota, but, and 12 centimeters slightly higher. Okay, next.
So other
Fine.
systems are normal.
Yes,
There
yes,
is no
yes. Fine, fine. Okay,
Uh,
summary.
Some-
Yes, summarize.
summary. 12-year-old male, known case of thalassemia major, diagnosed at 6 months of age, on regular blood transfusion, taking oral iron chelation, came with chief complaints of failure to gain weight and height for the last 2 years. So that is by mistake. Examination revealed hepatosplenomegaly. Possible complications of thalassemia major leading to growth failure could be irregular transfusions or chronic hypoxia, chelation therapy, hypogonadotrophic hypogonadism, hypothyroidism, nutritional deficiencies, or hypopituitarism.
Hello?
Yes, sir.
Okay. Madam Madhu, Madam or Ruchira,
Yes,
Ruchira,
sir.
do you want to ask anything or we should go ahead with the...
Window?
Dr. Madhu, you want to ask anything?
No, sir, it's okay.
No. Okay. Now she has presented a case of 12-year who's growing less than the expected, showing less height gain than expected for the last 2 years. And he's taking regular transfusion, regular chelation and all those things and still not growing well. Okay. So what are the possible complications? Yes, please.
Sir, I just wanted to ask Radhika, what are the things in favor of nutritional deficiency? What are the things she is saying that she is claiming it's nutritional deficiency, sir?
Ma'am, there is a mild calorie deficit in the diet
Right.
history.
Right.
Ma'am, as a thalassemia major patient, usually these people are prone to have vitamin D deficiencies.
Did you get it assessed?
Yes, ma'am, it is in investigations.
Okay, fine.
Okay. So what are the possible complications a thalassemia major can develop? And at the same time, quickly tell what are the possible complications that you see in thal intermedia or NTDT, what we call?
Sir, in
Major.
Sir, in thalassemia major, we can have complications like cardiovascular complications.
No, start systematically, Radhika, not like this. What are the possible complications that thalassemia major can develop? First, we start because of complications because of regular blood transfusion.
Yes.
So transfusion related complications, all the possible reactions of transfusion over this thing, hypervolemia, all those things can occur. And then most important because of transfusion are, one is under transfusion, these children will not grow. And second,
Over transfusion.
Transfusion induced?
Infections, sir.
Yes, they may get complication because of transfusion infection. Then third is the most common and inevitable complication because of transfusion, and that is
Alloimmunization.
That can occur in alloimmunization. In which condition do you see alloimmunization more common? Alloimmunization is more common when you start first transfusion late in life, after 3 years, or when ladies get transfusion during pregnancy, or those who are less transfused, transfused cases, they will get alloimmunization. But though we have 5 to 10% of thal major also because of repeated transfusion, they get alloimmunized. Okay. No, the inevitable complication of thalassemia is blood transfusion is iron overload. That is unavoidable. And unfortunately, our body doesn't have any mechanism to excrete this excess iron. And in thalassemia major, most of the complications that they get are because of iron, blood transfusion, chelation, and iron overload. While on the other side, anti-DT patients or thalassemia patients, they get complication because of hypoxia, chronic anemia, or because of
ineffective erythropoiesis.
So we restrict to thal major only, or TDT, what we call nowadays, the transfusion dependent thalassemia. So the second complication will be because of chelators.
Yes.
The side effects of the chelators, you have to regularly monitor these children for the side effects. No drug is without complication or without side effects. So you have to monitor them regularly for the side effects. And because of increased iron, what are the possible complications that they can get?
So the increased iron can get deposited in the liver, leading to chronic liver diseases.
Yes.
It can also get deposited in endocrine glands,
Yes.
like the thyroid, parathyroid, pancreas,
Yes.
adrenal gland.
Possibly all body organs, but liver
Cardiac
and
deposition is very
pituitary are very. In pituitary also, earlier we used to think that pituitary gets affected late, but now we feel that these growth effects, affected growth, and all those hypopituitarism symptoms appearing later, they may be the result of they are having high ferritin level in the early childhood also, because pituitary gets affected early, liver gets initially. All organs, all endocrine organs can get affected. Even kidney also can get affected, other than endocrine organs. The only organ or the part of our body which is not affected in thalassemia because of high iron is skeletal muscle. That is not affected. Okay, so we go to the next one now. How will you proceed now? How will you investigate? Forget about this investigation. How do you monitor the case of thalassemia who is 10, 12-year-old?
So we have annual checkups for thalassemia.
Yes.
So, sir, because now the child is more than 10 years old, so we'll have to do DEXA scan, sir.
First thing, in annual checkup or whenever you
CBC.
monitor a child, you should monitor their
CBC.
adequacy of blood transfusion, that they are maintaining regular good blood transfusion, pre-transfusion hemoglobin. Second is the chelation. Are they taking regular chelation or not? That is most important. Okay, then you will go ahead. What are the tests that, or what checks that you do?
So we'll
not
do,
annual, otherwise also.
So apart from this, we'll do SGOT, SGPT for liver, pancreas.
No, first you should mention, you should monitor their growth every 6 months, right from early childhood. That is very important in thalassemia. And record it. And then there are some tests which you do every month, especially a child who is on chelation, like those who are on Calfer. Ideally, we should do every 1 to 2 weeks, but we recommend that these children who are taking Calfer should get CBC done on every transfusion visit, at least, so that we don't miss. And important thing is that they must collect the report on the same day. Very often what they do, they get the test done and they collect the report next time when they come for transfusion. That is wrong. Okay, because if a granulocytosis has occurred this time, they'll pick up next time. Then the whole thing is lost in that. Then second,
The puberty, we have to check for pubertal
what
changes.
test do you do to monitor the monthly test you will do to monitor in case child is on deferoxyrox?
So we'll do SGOT, SGPT, urine analysis for proteinuria, and we'll do a pancreat, sir, for renal functions.
Yes, yes. SGPT, OT, liver function, kidney function, and urine routine every month if a child is on that. And in case of this thing, desferal,
So we'll do annual eye and auditory checkups.
yes, auditory, because and wherever suspected, you should do spine X-ray because
X-ray.
of their flattening
Vertebral.
effect, rickets-like, and all the side effects of desferal, which nowadays we use less often. Earlier we were using and seeing the side effects more often. See, all the side effects of desferal are seen when a child gets relatively higher dose of desferal as compared to the level of ferritin or iron overload. That means if the child is not iron overloaded and getting good dose of desferal, then the effect of test, because all the side effects of desferal are dose related. In India, we hardly get these things because desferal is so expensive and so difficult to give. So, okay. What are the other tests that you perform in a child with monitoring of thalassemia case, major?
So we'll do a T2 star MRI of the liver and heart to check for iron overloading.
What are you talking? See, you monitor in cases of thalassemia, Radhika, you monitor serum ferritin every 3 to 6 months.
Yes, sir.
And what is the recommended level of ferritin that you should maintain?
So below 1000, we have to maintain nanograms.
Yes, below 1000. This 1000 concept was when desferal was commonly used. Nowadays, we believe that we should maintain serum ferritin around 500.
500. Yeah.
Okay. And then now, other tests that you will do to rule out other complications are like liver function, kidney function, calcium, vitamin D that you will do. Then other after the age of 5 years,
so thyroid function test.
Yes, now they recommend, earlier it was 10 years, now they recommend 5 years onward to monitor T4, TSH. Other endocrine complication, when do you start monitoring them annually?
So from 10 years onwards.
Yes, because we have seen that most of the endocrine complication, cardiac complication, all these things appear after the age of 10 years. So what are the tests that you will do other than thyroid to monitor endocrine complications?
So pubertal checks we'll do for delayed puberty.
Yes.
For thyroid, we'll do for hypoparathyroidism. So we'll check the calcium, PTH level, magnesium, ALP. So for diabetes mellitus, we'll do
glycemic and blood sugar you should
test.
do. OGTT is recommended when?
So if we have clinical features suggesting that the child could be a diabetic, then we'll do an OGTT test.
If the child is in glucose intolerance range, or if there is a strong family history of diabetes, then after 10 years, annually we should do GTT, oral GTT.
Yes, sir.
And you know how to do oral GTT?
Yes, sir.
Yes. In a child, what is the criteria? But how do you perform?
So we'll ask the child, we'll give 1.75 grams per kg of glucose, and after 2 hours, we'll check the plasma glucose levels.
Earlier, we were doing 30, 60, 90, and 120 minutes, but nowadays we go for 0 and 2 hours after giving 75 grams of glucose or 1.75. Okay. What other things you will do to monitor? SMR scoring.
Yes, sir.
After 10 years, every 6 months, you should do SMR scoring on male and female children and record it. Okay. And then what are the other tests? Annual tests to monitor transfusion-induced infections.
So viral markers, we'll check for hepatitis.
Yes, that
HIV.
you should do from the beginning. Every year, not after 10 years, from the beginning, every year, HIV 1 and 2, HCV and Hepatitis B,
HBsAg.
auxiliary antigen, and we do generally anti-HBs,
Titles. Yes.
antibody titer, so that we maintain antibody titer about 10 units so that they are in the protective range. Other than these, what are the tests that you perform after 10 years to monitor?
So for cardiovascular, we do echo.
Echo or
Sir, apart from this, we'll do 25 vitamin D testing.
vitamin D ho gaya. DEXA scan you should do.
Yes, sir.
Ultrasound you should do, and wherever required, you should go for X-ray of the wrist and hand to detect the bone age and spine if you suspect flattening of the vertebra. And nowadays, a new modality which we have been using for the last almost 10-15 years, that is T2 star MRI. It's recommended that we should go for T2 star MRI and echocardiography after the age of 8 years. Every year we should do it. T2 star MRI, what is the advantage of T2 star MRI in monitoring iron level?
So it can detect iron levels before we can have echo findings. So it helps control the iron overload.
We can monitor the chelation also.
Yes, sir.
It gives you quantitative estimation of iron in the heart and liver.
Yes,
Like
sir.
if the units are milliseconds. If the heart shows more than 20 milliseconds value, then we can relax that heart is not iron overloaded. Okay.
Yes, sir.
So T2 star is very important, and if it is normal once, you can avoid and you do it every 2 years, not necessarily every year. We can do it every 2 years, but if it is less than 20 cardiac value, then we should do it every year. And if it is less than 10 milliseconds, that means moderately involved heart, then we should do it even more frequently. Okay, coming to this case, your case, how do you investigate? Can you show us the reports that you had, or before that, you tell me what is your plan to investigate this child?
So we'll first send basic tests.
Yeah.
So we'll first plot the growth, and we'll see if there's a slowing of growth or short stature is actually there, which should be less than 2 standard
Not
deviations.
grossly short stature or weight is almost not near normal, but okay, we can say that his growth is retarded for the last 2 years. So we have to be careful and we have to monitor. Will you do X-ray wrist and hand to assess the bone age?
Yes, sir. So then
How
we
do
can
you
see.
assess the bone age?
So there is Grulek and Pyle method, and there is Tanner Whitehouse method. We can assess from
we
them.
are doing Tanner Whitehouse TW2 scoring, and there is another way of assessing the bone age. And what does it imply, bone age?
So
Why do you assess bone age?
So we have to see if what is the relationship between the bone age, the chronological age, and the height age of the child. So if the bone age is severely delayed, then we'll have to look at reasons why the bone age is affected.
Most of the time, endocrine disorders delay the bone age very much, and especially thyroid. Thyroid can affect bone age. If it is occurring for a long period, you will find grossly retarded bone age in those cases. In cases of growth hormone deficiency also, we have low bone age. Bone age less than, by more than 2 years of the chronological age. I mean, bone age less than 2 years of the chronological age is significant, and we should start investigating for the endocrine problem. Okay, can you show us your case? Next slide.
Yes, sir.
You just showed us, thalassemia gene mutation.
So the thalassemia gene mutation was IVS15, IVS15.
What does it mean? How many
Homozygous.
IVS15? What does it mean? What is IVS15?
So it is the gene mutation behind the globin,
Yes.
beta globin.
How many mutations we know today? We know more than 300 mutations for thalassemia, beta thalassemia these days. Out of these, 28 are seen in India, and of these, only 5, 6 make 90% of the bulk of thalassemia. And what you are showing here, IVS15, that is the commonest mutation we see in India. It is seen all over, practically seen in India, and one of the common mutations that we see. It's also seen in Sindhis, Punjabis also. Fine. And XMN polymorphism,
It's
negative.
negative, sir.
Generally, we see XMN polymorphism when the mutation is IVS11. And those who have plus homozygous for XMN, they have milder variety of thalassemia they presently. His pre-transfusion hemoglobin is 9 to 10, reasonably good. Ferritin is also high, but not very bad that we see. Okay.
Vitamin D is 28.9.
Above which level of ferritin do you expect cardiac involvement?
So 2500, usually we'll expect mortality to increase.
Yeah, that is Nancy O'Leary's study of 1996, I think. So is vitamin D is low?
Yes, sir. It's on the lower side.
But that is, I don't think that will be the only cause for his growth, delayed growth. Or any other thing that you have positive? No. Okay, we go to the next.
Yes, sir.
Oh, yes, you have here. T4 is less and TSH is less. So you find you have got the
hypothyroidism, sir.
Yes, you got hypothyroidism. Clinical overt hypothyroidism. DEXA scan is also low. That may be a contributing thing because of that. But below which score, Z score, do you consider this? Is this osteopenia or osteoporosis?
So this is osteoporosis because -2 standard deviations for Z score. It is considered osteoporosis. With
-2.5.
-2.5.
3.2 is less than -2.5. Remember, we are talking in minus. It appears it is more than 2.5, but it is -3.2. So it is less than -2.5. So a child is more prone to get fractures. Fine. Now coming to hypothyroidism, you have picked up the cause here. So what is subclinical or compensated hypothyroidism?
Sir, in subclinical hypothyroidism, TSH would be high, but free T4 would be normal.
Till what level generally you see?
Sir,
TSH will be generally around 8-10 and T4 will be normal. That is compensated. Generally less than 8. But here T4 is also low, TSH is high. What is this? This is?
Overt hypothyroidism.
Yes, it is overt hypothyroidism. Do you treat patients with subclinical hypothyroidism in thalassemia?
Sir, if the patient has TSH more than 8, then it is recommended that we can start.
If TSH is more than 8, even if the T4 is normal, tomorrow he is likely to have hypothyroidism. So we start them on low dose of thyroxine. But here, this child definitely needs treatment. Yes. How much treatment how much thyroxine do you give?
So we give 2 to 4 mics per kg per day, but we'll start at a lower dose.
Not in the beginning. How do you start it?
So we'll start with 1 mics per kg.
Your child's weight is almost 30. So will you start on 100 micrograms?
We'll start with 1 mics per kg, sir, and then we'll
gradually increase. After 1 month, you get the TSH done. Titrate it, and then you go ahead with the increment in this. Every time you increase by 1 microgram. Okay? Till you have the TSH value less than?
Sir, less than 5, sir.
Yes. And did you go for bone age in this child? Has anybody done bone age?
So bone age was not done. We are advised in the OPD.
Sir, may I?
Okay. Yes, madam.
May I come? Okay. Sir, just I wanted to ask from Radhika, will there be any role of doing vitamin B12 and folic acid in such patients as a part of initial assessment? And one other very important aspect of overall, if we look at the whole holistic development or holistic assessment, then psychological assessment is also one of, I feel, is a very, very, very important.
What you
Yes.
mentioned, madam, is very important because these children have lot of problems. As I mentioned, when they grow to the age of 10, 12 years, yes, they see their peer group. They get that complex. Why me only? Why should I take chelation every day? Why should I go to the hospital for blood transfusion? ये बागी हो जाते हैं. They don't take the treatment at that stage. So we have to regularly motivate them, give them incentives, and so that they continue treatment. Very important. And emotional factor is one of the reasons for delayed growth in some children. Absolutely right.
And also, sir, along with that, I feel that sexuality issues also need to be told to them.
Yeah, that they,
That's
because
also
this
very
child
important.
is just 12 years, will be coming to that, and will go after that because see, he's in pubertal age. What is the madam has asked one thing important. Radhika, what is the definition of delayed puberty?
So delayed puberty in girls, it is described as a lack of pubertal development by the age of 13 years, and in boys it is 14 years.
Okay, and then you must, those who are managing thalassemia cases, they must have seen that these children, they have delayed puberty. Almost 40% will have delayed puberty. And some of them, even well managed, will have delayed puberty. And see, some of them, they have onset of puberty, but there is arrest of puberty. Puberty does not progress. What is the definition of arrested puberty?
Sir, if there is lack of pubertal progression for a year or more, so testicular volume in this would be around 4 to 6 ml, and
Yeah,
breast
means
development.
see, initially the testicular volume started increasing, but then it stops increasing. The progression of puberty is arrested for 1 year, then we call it arrested puberty. Or if the menarche does not follow the thelarche by 5 years, then also it is arrested. Okay? And what is hypogonadism? All these definitions, all postgraduates should know. What is hypogonadism?
Hello, sir.
Yes. Hypogonadism, Radhika.
Yes, sir.
दूधू से join किया है कविता तूने?
Hello. Hypogonadism is so when there is testicular volume is less than 4 ml, and there's no breast development by the age of 16 years in both boys and girls.
Yes. I just want to ask the organizers, can we take 5-10 minutes more?
Yes, sir.
I know.
Absolutely, yes, sir.
Okay, we'll finish this hypogonadism part since madam has mentioned that. So we'll go ahead with the hypogonadism also. That's a very common problem. See, the most common problem in thalassemia is hypogonadism because they are growing now. Earlier they were not growing. We never realized it. Now they are growing. And it gives a lot of psychological impact also. They don't develop their facial hair growth. Their sexual characters also don't appear in many children. So we have to take care of the hypogonadism. Growth, okay. Now we found the cause of growth hormone. Otherwise, if you we find other causes of growth or other complications which can affect growth, we treat accordingly, and most of them they respond. Growth hormone, I just want to mention few things about growth hormone in thalassemia major. Radhika.
Yes, sir.
Have you read about growth hormone deficiency in thalassemia?
Yes, sir. There is growth hormone deficiency and resistance in thalassemia major patients.
Yes, growth hormone is again a common problem. And in fact, before puberty also, it can affect the growth of the child. And if you see the growth hormone, the growth hormone is less. First, there is resistance to the response of growth hormone. Then in some children, the IGF-1 levels are also low. because of the liver involvement, because they are produced in the liver. So the response of growth hormone in thalassemia patients is also blunted in some cases. So when do you do growth hormone testing in that?
So we'll do an IGF-1 and IGF-BP3 levels. If they are
That
low,
is a
then we'll do.
screening. You can say, yeah, screening for that. But if I say, how do you diagnose, confirm growth hormone deficiency? Tell me one or two tests.
So we can do a growth hormone stimulation test.
Yes, very good. What are those tests? Quickly.
So we
If you
can
know,
trigger
say
using.
yes. Otherwise, I'll tell you.
So we can
You know?
trigger using clonidine or insulin. So clonidine we are giving at 5 mg per
Insulin
kg.
nowadays we are not doing. Clonidine is the commonest test. Clonidine simulation test we call that we
Yes, sir.
do in our OPDs also. We just admit in the daycare. Some people are doing in the OPD also. You give empty stomach, you call the child, give
Yes, sir.
clonidine 5 microgram per kg. And then you take the blood sample for growth hormone assay at 0, means when you give the 30 minutes, 60 minutes, 90 minutes, and 2 hours. After that, you give child to eat everything. And then if you find the levels of growth hormone in the blood less than 7 nanogram per ml, then you call it growth hormone deficiency. And 7 to 10 is borderline. So we have to observe them very carefully. Growth hormone deficiency also delays the bone age by few years, right?
Yes,
And
sir.
there are other tests also, but in thalassemia, if we find one test positive, though ideally we should have 2 growth hormone stimulation tests positive, but even if you have one test positive, and there are other pituitary related endocrine affected, then we give them growth hormone. Though the treatment is very expensive. And what time do you give growth hormone? How it is given?
Nighttime. So we
No,
give it
how it is.
subcutaneously nighttime.
Yes, these are like insulin. We have pens for growth hormone, though it's very expensive. 1 unit of growth hormone almost costs around, I think, 300 rupees. And 0.1 unit in thalassemics, sometimes we give 1.15 unit because their response is blunted. When you give growth hormone, the response is not as good as in other conditions. So we give a higher dose in thalassemics. And though if you give to a 30 kg child, 0.15 means 4.5 unit per day. That means about 1,500 rupees per day is the treatment cost. So roughly around lakhs, 4-5 lakhs per year. So it's very expensive. Anyway, now coming to hypogonadism, Madam mentioned, how do you diagnose hypogonadism? Which type of hypogonadism do you see in thalassemia? Hypergonadotropic hypogonadism or hypotropic hypogonadism?
So hypogonadotropic hypogonadism is seen.
Yes, hypogonadotropic, because what does it mean?
So pituitary itself is producing less hormones. So
pituitary is
because
affected in these children. You see, in thalassemia children, the gonads are preserved. Testes are not that badly affected. Ovaries are not affected. So if you induce puberty in these cases, then the girls can conceive and boys can have spermatogenesis normally also.
Right, sir.
So they have gonads preserved, but their puberty doesn't start. What do you do? How do you diagnose hypogonadotropic? What will be the value of FSH-LH in these cases?
Sir, can we summarize it now, sir?
Yeah,
I know,
we'll just take for 1 minute. So I'll just mention that when we find hypogonadism in these cases, we try to induce, means in males more than 14 years, girls more than 13 years, we try to give them hormones, replacement therapy, and we induce puberty. Like to male children, we just give testosterone low dose so that the bone age is not advanced. Their growth continues, 50 milligram per month to induce puberty. And we give it for 6 months every month. And in many children, we find that we don't have to give further. Puberty stops spontaneously. After that, it gets stimulated. Similarly, to the girls, and if it doesn't start, then we give for another 6 months to 1 year and wait. And then for girls, we give them estradiol low dose, 2.5 to 5 microgram per day. And then they also start with the puberty in most of the cases. We have not found any definite solution for their facial hair. Even if you give them testosterone injections, their facial hair sometimes not grow. I read in only one paper, and I've tried, it does work, that the testosterone gel is available nowadays. We apply, but I don't recommend it here. Please don't take this message that you apply testosterone gel on the face and beard will start growing. It is still experimental. There are just 1 or 2 papers on this. So
Right,
that's how we induce puberty in these cases. Anybody wants to ask anything on the
Sir, there are few
complications?
questions in question and answer. Can you
I'll take up those questions
right, sir.
quickly.
During this time, I would like to
Dr.
welcome.
Dhankar.
I'll just tell them.
Dr.
How we
Dhankar.
diagnose?
Sir, Dr. Ruchika, please.
Yes,
Sir,
Dr.
Khanna sir,
Khanna.
please. Khanna sir, please.
Shall we take 1 or 2 questions from this?
Sir,
Quickly, do
we would like to answer.
hypersplenism present with petechiae or they are asymptomatic?
Sir.
Hypersplenism may give rise to thrombocytopenia, and these children may have petechiae. Then, sir, a transfusion-dependent thalassemia who has retroviral disease is on ART. Then, what more parameters need to be monitored? Any drug interaction do we see? No, we don't see any drug interaction. And then they have to continue that ART for lifelong. We have to see that their level of their CD4 levels are in above 250. If they are less, then they have to be. In this case, management of these cases, I will suggest that please take help of infectious disease or HIV expert in those cases. And then sir, I have a patient who wants to get dental treatment done. See, we must keep in mind, if they are trying to go for those dental wiring and all that, those things, then just remember that their bones are osteoporotic. So it may not be very safe, but we don't recommend this procedure before the age of 12, 13 years, before their facial development is there. Then how long to give growth hormone? Till we have achieved the required level of growth, or if the bones are fused. See, we grow when our bones grow. If the long bones are fused, the epiphysis and metaphysis, there's no point giving growth hormone. Child will not grow at all. Rather, he will develop side effects of the growth hormone like thyroid, hypothyroidism, precipitation, or diabetes or other things.
Right, sir.
Is there role of regular folic acid? Yes, we do recommend folic acid supplementation to all thalassemia major cases. 1 milligram per day is recommended, but since we don't have 1 milligram tablet, minimum is 5 milligram tablet. So we say that 2 to 3 times a week they should take this, and I give every alternate day this 1 tablet or half tablet a day. Can we induce puberty in Down syndrome this way? Yes, there are set criteria for giving puberty in Down syndrome also. That is given in the textbook. So.
Right, sir. So Dr. Ruchira wants to, sir, that's a
yes,
great...
please, madam.
Dr. Ruchira wants to ask something.
Yeah, that's what, sir, I was telling that, okay, if we are doing it, then we should have a baseline B12 and folic acid done in each and every patient. And I feel in this patient, I think somehow I couldn't see the values of B12 and folic acid.
Yes, you're right, madam. But folic acid he was taking regularly. So we don't expect folic acid deficiency. And that way, that will not affect that much growth. But when we see that there is low PLC or platelets, we have got cases who have gone in megaloblastic crisis because of B12 deficiency. then in that case, but otherwise, I fully agree. She should have got that done. Actually, the case came to them only a few days ago. Yeah, folic acid, actually, you see, in thalassemia, you must have seen that we give folic acid every day or alternate day, but we don't give B12 to these patients because we have seen that the clinical relevant improvement or benefit of giving B12 on daily basis is not seen in thalassemia. Deficiency may occur. I fully agree with you, madam. That is true. We have seen cases of even crisis, means megaloblastic crisis also. I had one case who was not improving in spite of splenectomy and all that, and then we found that folic acid deficiency, B12 deficiency was there.
Dr. Madhu also wants to ask something.
Yes, madam.
Yeah. Yes, sir. So I just wanted to ask that this boy is having growth faltering, that is mainly in terms of height. So should we consider zinc deficiency and whether the zinc level should be estimated or not?
Zinc level is recommended every year. In fact, after 10 years of age, it is standard recommendation, and especially those who are diabetic and on calfer. Then it causes zinc deficiency in them. Because zinc deficiency is a known cause of growth impairment.
So true, sir. So true. Calfer, the culprit.
Yeah, calfer. In diabetic, zinc should be monitored. Otherwise, we might have, if it is low, we give them 50 milligram per day zinc supplement.
Right, sir.
Any other comment or anybody else?
No, sir.
Dr.
It's
Lalit,
fine.
I can see thinking something.
So very nice. Always, Dr. Khanna, we have been associated with IAP for this thalassemia unit and society also. Every year we are celebrating thalassemia. I want to know what is the impact of the prenatal screening. We used to have 10,000 thalassemia major buzz.
Yes, very big impact because
What is the
now many hospitals, many nursing homes, they have started doing screening, especially in Delhi. What case I got yesterday was from Rudrapur, not from Delhi. But in most of the cases, from Delhi, we have started getting much less cases now of thalassemia major because most of the nursing homes, even gynecologists, they have got this thing in their mind that thalassemia screening is a part of. So government has not made it mandatory. We have discussed that ministry level many times. They have not made it mandatory test, but it is a recommended test as it was mentioned by Dr. Mukesh, I think.
Sir, I mentioned it. We
yes,
do it.
Yes, absolutely right. It is a recommended test. It is strongly recommended by FOXI, the Gynecologist Association. But it is government people say that they cannot make it mandatory because of some reasons, administrative problems.
Just one more.
But nowadays, our obstetricians are doing these antenatal screening. The moment they come in first contact with the pregnant lady, they go for CBC and all that. And nowadays, instead of screening, many of them are just writing HPLC on the first visit only so that they don't waste time.
Right. And another important thing just I want to add is that
many antenatal tests done in our hospital.
And sir,
Dr. Please add, sir. Dr. Lalit, please add.
Just one thing, just addition to that, the immunization of these kids is very, very important aspect because the infections are the key. So that is very important. The rest we all
consider them actually immunocompromised. So if they get chickenpox, we give them Zovirac, means acyclovir. It is recommended. Their malaria, their typhoid is also more severe than normal children. If they get dengue it's documented. There are so many papers on that. Dengue is much more severe in thalassemia than other normal children. You will see many of them will end up in ICU. So they get infections are more common, severe in thalassemia. So all available vaccines, even I recommend that they should get pneumococcal vaccine also. Even if the government people are not giving, they should get it.
Right, sir. Sir, I would also like to take this opportunity to welcome, just not to welcome, but also request Dr. Shyam Sundar Veena and Dr. Pankaj Garg. Dr. Pankaj Garg is our president-elect and Dr. Shyam Sundar is our to add any comments or to say whatever they have to add, sir. Dr. Sham Sundar, Pankaj.
Mukesh, I would like to add because I am a
Sir.
gastroenterologist here.
Please go ahead, Dr. Sham.
Because in the THEL children have the transfusion dependent because they have the risk of the hepatotropic or non-hepatotropic blood-related infections. So their children periodically screen for the especially hepatotropic infection like the hepatitis C because they are the easily treatable disease by the very good combination therapies available even in the government supplies. So that children is periodically screened for that. Second thing, that child is properly immunized even before once the child you diagnose, then immediately immunize for the especially hepatitis A or hepatitis B. And second thing, because the child on the blood transfusion dependent, that child have the hyperinsulin features. So that hyperinsulinism may be required the splenectomy. So their children properly immunized for the capsulated organism or like the influenza viruses. And third things, because these are the many, especially thalassemia trait or intermediate, sometime diagnosed as a biliary stones, and subsequently we did the workup for the stone, they find out the hemoglobinopathies like that. So those are the children, especially trait or intermediate or have the stone, you should always do the SPLC for the hemoglobinopathies because it is one of the important cause for the GB stones in the children's.
Yes, you are absolutely right, Dr. Sham. We regularly, I think you joined late because we mentioned that we regularly recommend that they should be screened for hepatitis C, HIV, and hepatitis B and anti-hepatitis B titer every year.
Exactly.
From the beginning.
Very good.
And secondly, gallstones are more common in thalassemia intermedia or NTDT patients.
Yes.
Thalassemia minors, they don't have gallstones, but intermedia, definitely, absolutely right you are, that they have. In thalassemia majors, we do get gallstones, but less often, much less as compared to them.
Right, sir. I would just like to add, Dr. Sham, the splenectomy is not that common in thalassememic children.
Nowadays, we avoid splenectomy.
We avoid. It's very rarely we take that decision. Very rarely.
Absolutely right, Dr. Mukesh. We avoid it, and as far as possible, we preserve the spleen. 15 years, 20 years back, we used to do splenectomy in thalassemia intermedia cases just to raise the hemoglobin by 1 gram. But we have realized that it is a very risky procedure because the risk of post-splenectomy thromboembolic complication and infections
thrombosis
are very high. Thrombosis can occur even after 8 years, 10 years of splenectomy.
Exactly. So, in fact, sir, go ahead, sir. Dr. Pankaj, please.
Dr. Khanna, sir, we always debate that thalassemia is a preventable disease, and still we are not able to prevent it because of non-universal recommendation of not using HbA2 in routine practice.
Yes.
So I am accompanied by my wife, who's also an obstetrician. So she wanted to say something. Let her say this.
Please,
madam. Yes, Dr. Manjusha. Dr. Manjusha, please come.
Manjusha. Thank you, sir. Thank you. Sir, my only thing is that nowadays we are the highly knowledgeable patients. So litigation rate is very high. Recently, one of the even IVF patient has sued the doctor for not doing thalassemia, even before planning the transfer of the egg and all that. And it is in Delhi only. And
Yes, I know. I had a case done in a very big hospital, IVF case, where the donor was not screened, and it turned out to be E-beta thalassemia. E-beta thalassemia.
Yes.
The problem is it won't stand in the court because there is no law which says. That is what we want. I hope when Dr. Pankaj, he also continues this fight when he becomes president next year. And I will suggest that Dr. Alok Bhandari and Dr. Mukesh should take up this issue with the ministry because they are not making it mandatory. We have so many times suggested to them. They are not making it mandatory. Unless they make it mandatory, nobody can sue you. It is recommended. I can say that it is recommended, but I felt that it was not required. What can you do in that case?
So even if we are saying HbA2, there may be logistic reasons from government to say this.
Patani,
So-
I don't know. We have discussed many times at ministry level.
So even
don't
if
know why
it is not HbA2, can
And not
measure
HbA2.
the
Even if they screen for thalassemia, they can go for Nestroft if they want a cheaper alternative.
Yes, Nestroff is a better
There's
idea.
so many things
Sir,
available,
Nestroff
but they
is all
don't agree.
fallacies.
I have been
Nestroff
fighting,
is all fallacies.
I have been fighting almost more than half of my life for this, but they are not making it.
This should be done.
So,
I have a one
Mukesh,
story.
you are in
Mukesh.
government sector, so maybe you must be able to understand why government is not doing this.
No, they
So-
they say they don't come
They
up
will
with
come
a solid reason. They say that we have some administrative reasons for not doing it, making it mandatory. Because then people will start. See, what we are talking about is the cities. When government makes a thing mandatory, they have to provide the kits and everything in the remote areas. They have to
Yeah,
provide HPLC machines in the remote areas.
Right.
You can't say that send all
government-
pregnant ladies to district center to get the HPLC done. There are many factors like that. We have discussed it at length in these ministries.
right, sir. Sir, Dr. Lalan Bharti also, I think Dr. Lalan Bharti also has a question to ask or a point to share.
They will
Dr.
come.
Lalan Bharti. Sir, Dr. Pankaj, please
Yes,
go ahead.
Thank
sir.
you so much. Thank you.
No, go ahead, sir. Dr.
Dr.
Pankaj, you can
Pankaj?
go ahead. Dr. Pankaj,
Please,
you can go
Dr.
ahead.
Pankaj,
Please
Said
go
a
ahead,
day
sir.
will come.
Khanna
Said a
sir,
day will come when
it
it
is
will
very
happen.
well, Dr. Khanna sir, it is very well explained. Everything is very clear. But as far as government is concerned regarding the screening, so that depends upon the severity, whether the treatment is available, which area it is more prevalent. So logistic issues are there, but
yeah,
but in
logistic or administrative problems are there. That's why they can't
yes, sir.
implement.
For as the madam was talking about that, so if you tell the patient that the tests are available, right? We need to tell
Yeah.
the patient that tests are available. And if we explain everything, then we are not responsible for that. And that will not stand in the law.
Yes, even unless it is made mandatory, it can't stand. But the only thing is this you can tell in private sector. If you
Yeah.
tell in government sector that these tests should be done, they are available, but I can't do it. See, they will immediately demand that why can't government provide us these machines when they are recommending this themselves? They are saying it is mandatory. On the other hand, they are not providing with the machines. So these are logistic problems. They are administrative problems. So many things. That's why they are not able to make it mandatory.
Right.
Right, sir.
Right.
Right, sir. Dr. Madhu, Dr. Ruchira, would you like to add anything? We really want to hear from you. Dr. Madhu Sinha, Dr. Ruchira Gupta, would you like to add anything? Right,
No,
probably. Dr. Madhu, please.
Yeah. Sir, I think it's all done, and all the comments were very good. And we got an opportunity to learn so much from you, sir, because we are not a thalassemia expert.
No,
So it was great learning from you.
So
sir.
nobody can be as expert as Khanna sir. So we are grateful to him without any
So
second.
not only is an expert, he's very passionate about
Passionate also.
Teaching.
Exactly. So he has devoted 4 decades. So it's a big time.
So,
without
so
any
Mukesh
When
bhai,
Dr. Mukesh, I can be in touch with you to learn so many things and to ask you many things.
Ma'am, I am
It
just
would be
starting.
great.
I'm just starting. I would like to be like Khanna sir someday, but it's a long run. No doubt about it.
And Khanna
It
sir
would be my
taught a
pleasure
lot.
if I'm like sir.
We are really
खन्ना
feeling
सर
great.
का तो पैटर्न है, इसको फिर से कराना है। मुकेश फिर से भी एक लेक्चर इसका
Yes,
कराइए।
sir. Khanna
Yes,
sir.
I agree with Dr. Lalan. More sessions we want, sir, with you.
Oh, sir, ko we can request again. That should not be an issue.
My
So, any other comments and questions from any of our Dr. Ruchira, Dr. Sham, Dr. Pankaj, Dr. Lalit Mendiratta? Any concern, any question, anything which you would like to, any comment or any question before we close this session? Or Khanna sir, finally. Sir, final words of wisdom.
I'll say that Dr. Ruchira presented it well and very lucky to find out high TSH and low in this case, and she could solve the problem also very fast. So we give this child thyroxine, and I hope he'll grow well. And then, if required, later on, if he goes in for hypogonadism, then or hypo means delayed puberty, we can induce puberty in this child.
Great, sir.
Thank you, Dr. Radhika. You presented well. Well done.
Hats off to sir. It was a pleasure learning from you. Thank you, Dr. Madhu. Thank you, Dr. Ruchira. Thank you, Dr. Pankaj. Thank you, Dr.
I must thank Dr. Madhu and Dr. Ruchira for joining
and
us.
Dr. Lallan Bharti sir, हमारे favorite इंसान तो Dr. Lallan.
Yeah,
Dr. Lallan करते हैं.
बहुत पुराना जानते हैं sir. Thank you.
And heads off to Khanna sir, who has been mentoring the whole. It was a show of Dr. Khanna sir today, sir. Thank you very much, sir. Thank you. Thank you all.
Good night. Good night.
Thank you, everyone. Good night.
Bye.